Apter is a child and adolescent psychiatrist, educator, and world-renowned suicidologist, working with psychiatrists in primary care, medical providers to deliver suicide prevention and intervention programs, in addition to focusing on the sociological factors that contribute to suicide, especially in different populations. His training in biological psychiatry has also allowed him to investigate genetic and hormonal contributors to suicide risk. Dr. Apter's academic positions include both professorship and chairmanship of the Department of Psychiatry at Tel Aviv University's Sackler Faculty of Medicine. And he has been invited to serve as a visiting professor by the University of Pittsburgh's School of Medicine, the Karolinska Institute in Stockholm, the Yale School of Medicine, and the Columbia University Medical Center. Dr. Apter has previous experiences to build mental health capacity by training health professionals before, during, and after data collection. Thank you.
Adolescent psychiatrist, I'm going to talk about suicide in young people, which is my field. And basically, what I'd like to do is, first of all, review some of the descriptive epidemiology of suicidal ideation, attempts and completion. Then talk about risk factors for suicidality across the lifespan, and about diagnosis for the purposes of suicide risk assessment. And then review management and treatment of children and adolescents who are suicidal or at high risk of suicide. And perhaps talk a little bit about some of the research directions that we're doing at my hospital, which is Schneider Children's Hospital in Israel. So why is suicidality in teens so important? It's a leading cause of death, of course. It's one of the two major causes of death in the West, and children under the age of 19. It's also the most common reason for adolescents in the Western world to come to the emergency room. And again, in terms of Western culture, although it's quite rare for an adolescent to actually kill themselves, but it's certainly an indicator of many problems. So teen suicidality is something that's a really important clinical problem. One of the problems in when you're dealing with teenagers who come to the emergency room is the terminology. And in any study or any clinical program that you're dealing with, you need to try and be clear about the terms that you're using. So in the United States, an adolescent who takes an overdose or cuts themselves is usually diagnosed as a suicide attempt. Based on, if you ask the teenager why he did it, he will say, I wanted to kill myself, or I didn't want to kill myself. In the UK, people are less inclined to believe what the teenager says and use a more neutral term called deliberate self-harm. And then, of course, there are many teenagers who hurt themselves in all kinds of different ways. And Norman Kreitman from Scotland termed the term parasuicide to describe this self-injurious behavior. Another very popular term, especially in Western countries, I'm not sure what the situation in Guyana is, but hopefully we'll learn this as our project advances, is what's called non-suicidal self-injury, NSSI, which is self-cutting, which has many different motives, mostly not to kill yourself, but many other motives. And then there are teenagers who ingest foreign bodies. the FBI, which is also an interesting phenomenon. We have teenagers who swallow spoons. This is one patient of ours. So there's a whole set of different behaviors that can be subsumed under this heading of teenage suicidality. So basically, when we're talking about working in an emergency room with suicidal teenagers, there is a spectrum of behaviors which the clinician has to examine and then decide what he's dealing with and what the meaning of each of these behaviors is. They seem pretty obvious, but it's not always true. So many teens think about suicide, and we're still not sure what this means. How normal is it for a teenager to think about suicide? And how much is it a sign of danger? And this has become a major focus of much research in this field. I'll talk a little bit about this later. Then suicidal threats and suicidal gestures is also a common behavior in young people. And again, the nature of these is not quite clear. But many adolescents, especially those who come from populations that are not very powerful, such as where I have the most experience in low-ranking soldiers or in women, suicidal threats and suicidal gestures are often used. And sometimes it's not even pathological, because if you're a weak person, you don't have much power, then the use of suicidal threats and suicidal gestures can be a way to get things that you couldn't get otherwise. For instance, if you're being forced to marry someone that you don't want to marry, if you make a suicidal gesture, you have a chance of getting out of it. And so the question arises, who is more pathological? The girl who doesn't use this and marries the person she doesn't want to use to marry, or the woman who hurts herself or cuts herself? And this idea that suicidal behavior can actually be a sign of health in some populations has been popularized by Carol Gilligan, a well-known feminist psychoanalyst. The other behavior that is very interesting is deliberate self-harm, which I spoke about, or non-suicidal self-injury, which is an interesting behavior where usually again in women, there's self-cutting. And the self-cutting has, usually the motivation is not suicide, but it can be very different. It can be self-punishment. It can be relief of tension. It can be sometimes infectious. If one girl in a school cuts herself, then others will join her. And we, in our hospital, we have a ward for girls with eating disorders. It's very common for there to be epidemics of self-cutting in the eating disorders ward. And then, of course, there are actual suicide attempts where you know the adolescent really wants to kill himself, but it's very difficult to know whether what the adolescent tells you is true or not. And so we, as I said before, we often use the term deliberate self-harm in order to try and obviate getting into problems with motivational attributes which we can't really tell. The suicidal ideation is very common, and many adolescents think about suicide at some time in their lives. And this has become especially interesting since we now have digital ways of monitoring suicidal ideation called ecological momentary assessment, which I'll talk about later. But basically, it's using cell phones or other digital equipment to monitor suicidal ideation. And it's become very obvious using these techniques, and although it was even known before, that many adolescents think about suicidal ideation is very common in this age group. This is what I told you about before, the non-suicidal self-harm, which is an entity in itself. It often is comorbid with suicidal behavior, but it doesn't actually have to be connected with suicidal behavior. And this is an interesting study that we did, and you can see that there seem to be two kinds of non-suicidal injury. The one on the left, this one is related to kids who don't have a lot of parental support, and then the non-suicidal self-injury is probably related to some form of distress or depression. And there are other forms of non-suicidal self-injury where it's really a kind of infectious behavior, which actually leads to increased peer support. And again, this paradox that sometimes suicidal behavior may have some positive value for a young person, which makes the suicidal behavior in this age group complicated and interesting. Another interesting clinical problem is what we call the suicidal crisis syndrome. And again, we see this commonly in Western clinical situations. It'll really be interesting to see how common this is in Guyana when we do the project. But often suicidal behavior it's not something that's constant, but it comes suddenly and then goes away suddenly. It's somewhat like an asthma attack. So an adolescent who's doing quite well suddenly goes through a suicidal crisis, makes a suicide attempt, and comes to the emergency room. And by the time I get to the emergency room, when I'm on call, the adolescent feels much better and he wants to be discharged. And one of the problems in suicide prevention is that often we use the emergency room as the site to do prevention, but because the suicidal crisis syndrome is self-limited, this may not be a good place to do this. But the suicide crisis syndrome, as I said, become a focus of interest of us. It's a cognitive affective state. It recurs. It's much more common in adolescence. It comes in bursts. And basically, there seem to be a couple of factors that seem to be involved. One is entrapment, the feeling that I'm trapped and I've got nowhere to turn to. There's a lot of affective, a lot of high emotional tone. The kid loses cognitive control, he's hyper-aroused, and he may socially withdraw. This is the kind of thing we see in the emergency room. But the reason to call it a crisis syndrome, that it's often very self-limited. And again, this is when we try to refer these kids for help, they often don't go because the crisis passes and then they go home, everything's fine until the next crisis occurs. So this is an important observation, which I think needs to be looked at in different cultures. It's certainly common in Israel. Whether it's common in Guyana is something that would be interesting to look at, as well as as we go through, if our program goes as planned. So I think you probably have heard a lot about the epidemiology of suicide, but the epidemiology of suicide is very interesting. And basically, you've probably seen these slides before, but I just want to show you that suicidal behaviors are very much related to geography. So the very red color means high suicide rates, which you can see in the former Soviet Union, which has very high suicide rates. And then interestingly enough, in Mediterranean countries, they can be very low. And this can be very interesting in very small distances between high suicidal areas and low suicidal areas. For instance, in Slovenia, where I've done some work, Slovenia is a very small country, but it has one of the highest suicide rates in the world, but only around the capital, Ljubljana, where most of the population have closely associated with Hungary. But on the Adriatic Sea, where the more Mediterranean population, suicide or attempted or suicidal behavior is very low, and actual suicide is also very low. So suicide is very much a matter of geography. And again, another point that's going to be very interesting to look at in Guyana and the different populations to see where. This is just to show you what you already know, that suicide is an important cause of death in adolescence. But what many people may not be aware of, at least in my experience, people not so aware of, is again in the Western world, in Europe, and many states in the US, suicide rates are going down. And this is not often appreciated. You can see in Africa, in the Eastern Mediterranean, Europe, actual suicide rates in this age group are going down, although in America there's a little bit of a rise. And the reason for this decline is we don't know. It may be due to better treatment of adolescent depression. And it's one possibility. But it may be due to our useful suicide prevention efforts. Maybe that's also true. But we don't know. And again, it's something that's going to be interesting to look at in the Guyana project. Another interesting phenomenon in adolescent suicide is what we call the gender paradox. So Israel is very similar to the Western world. It's 75% of actual suicide in Israel are males, whereas 80% of attempted suicides are females. So you have this gender paradox that attempted suicide is more common in females than males. And this is true for the Western world, but for India, China, Sri Lanka, Pakistan, and also in Guyana, this is not true. And suicide is just as common, if not more so in women than in men. Another very interesting exception to this gender paradox is in anorexia nervosa, which is a disease of women, but has a very high suicide rate. In fact, of all the psychiatric illnesses, anorexia has the highest suicide mortality rate, more than for even depression. And as I said before, one of the interesting things that I've seen in my work in the Israeli Army, the Israeli Defense Force, that both suicide and attempted suicide are more common in males. So males, especially soldiers of low ranks, often attempt suicide. And this is in line with Carol Gilligan's ideas that in certain populations, attempted suicide may actually not be a sign of illness, but a sign of health, a way people fighting against their destiny to be forced to doing things that they don't want to do. Another very interesting phenomenon which has been investigated a lot is the role of psychopathology. So this slide shows you results of psychological autopsy studies that were done in Israel. And what we found was that most kids who kill themselves have major psychopathology in these studies. But this may be not true. I know that Professor Hoven doesn't think this is true. And certainly it doesn't seem, it would be very interesting to see whether in Guyana, in fact, this idea that major psychopathology is the major driving force for suicide is right. Or maybe social conditions are much more prominent as a cause. So whether or not psychopathology, mood disorders, bipolar disorder, substance abuse, borderline personality are related to suicide, or whether suicide is more related to social causes, is what I would expect that we will find in Guyana. So this is a Western side. It probably doesn't apply to the populations that we would be looking at in Guyana. Another very interesting predictor of suicidal behavior is sleep. And we're only just beginning to realize in adolescence how pathology related to sleep is an important predictor of suicide. We found this in our own studies. This is a study from Pittsburgh, and they found that insomnia in young people and adolescents predicted a 5-fold increased risk for suicide compared to controls. So when you're assessing an adolescent and seeing whether or not they're in danger of committing suicide, taking a detailed sleep history is something that's highly recommended. And of course, availability of lethal agents is really become probably the most cogent suicide prevention act or intervention in adolescence. Studies in Switzerland and Israel have shown that the presence of guns is very dangerous in terms of suicide. In Britain, they showed that detoxification of domestic gas brought down the suicide rate very, very dramatically. Using blister packs for pills, where the adolescent has to spend some time getting the tablet out of the pack instead of just swallowing the pills from a bottle in one fell swoop. Pesticides are also, when they're present in the home, are an important facilitator of suicide. Barriers on bridges. So availability of lethal agents is something that we always look at when we're assessing suicidal adolescents. Now, based on our psychological postmortems, which is something that we do on all the suicides in Israel of young people under the age of 21, these are mostly soldiers in the Israeli Defense Force. We've come up with 3 personality constellations that seem to be characteristic of many different suicidal adolescents. One are high-functioning suicides, such as students who do very well and then suddenly fail, or soldiers in elite battle units who suddenly fail to do something that, like opening a reserve parachute, when it wasn't really necessary. So this is the narcissistic, perfectionistic suicide, which is also defined in students at universities such as Yale and Oxford, where a student who has to do well all the time suddenly fails. That's very dangerous in terms of suicide. And in the army in Israel, we've also learned from this that soldiers who drop out of prestigious courses, such as a pilot's course or a commando course, are at a high risk for suicide, and it's a time to make very intensive interventions. So the other constellation we see are kids who are very impulsive and aggressive. This often you see in people who are diagnosed with borderline personality disorders. And then hopelessness, which is often related to underlying depression. And this is probably one of the major reasons that you see such a high suicide rate in girls with who suffer from anorexia nervosa. So the impulsive aggressive constellation is, as I said, in borderline adolescence, is a very common thing that we see in adolescence in Israel. It relates to the dynamics of suicide, which were classically described by Menninger many years ago in his book, which he published in 1933, the wish to die, the wish to kill, and the wish to be killed. And we often find this as a basis, as a dynamic basis, in these very impulsive, aggressive adolescents who kill themselves. Another interesting constellation, which we see in Israel at any rate, but I know that it's seen in the States also, is that there seems to be a relationship or a high correlation between problem behaviors and suicidal behavior. And the Jesser, who is a social psychologist, he looked at this behavior. He looked at these behaviors. He called them problem behavior theory, and he found that problem behavior theory accounted for many self-destructive behaviors or health-related, health risk behaviors. And then that further research showed that these problem behaviors are very much related to suicide. So this is a slide showing all the different health risk behaviors that seem to be highly correlated with suicidal behavior. And so that when we're thinking about suicide prevention, we also have to think about smoking prevention, drug abuse prevention, alcohol prevention, and the whole series of what Jesser would call unconventional behaviors or health risk behaviors. The last constellation, which I already mentioned, is hopelessness. These girls with anorexia, they try to get out of it, but they cannot do anything except think about food. And there's a very famous case of Ellen West. Ellen West was case was treated by the Swiss psychoanalyst. Who was an adolescent who was treated for anorexia for many years. She improved and then she relapsed. And she said she couldn't continue living while she could only think about food, nothing else. And this is a dynamic which is seen in these girls with anorexia, who often kill themselves. And in fact, in our hospital, we've had very few suicides in our depression and suicide clinic, and the vast majority of suicides, youngsters who actually kill themselves, are from our eating disorders clinic. And again, it's this feeling that they have a problem that they just can't get out of, which is wanting to be thin and not being able to be as thin as they really want to be. Another interesting characteristic of this hopelessness constellation, which you see in young people who are beginning to develop schizophrenia, and especially schizophrenia with good prognosis. So in good prognosis schizophrenia, these young people have a lot of insight and realize that they're losing their minds, that they're developing a serious illness, and then they kill themselves. And so this is a slide of a study that we did showing that the more insight you have into your schizophrenia, the more insight you have into your psychosis, the more likely you are to have suicidal behavior and hopelessness. And this is the Calvary Depression Scale, which measures depression in schizophrenia. So contrary to what you would think, insight is not necessarily a good thing. It may, in certain adolescents, actually be a dangerous sign. So looking at, this is a study that we did using the SAILI study, which Vladimir talked about in the previous lecture. But what we did was we looked at 12,000 adolescents with suicidal behavior in the SAILI study. And what we showed was that we were comparing the JESER approach, which is in red. We see conventionality, unconventionality, leading to high-risk behaviors, and then leading to NSSI and suicide. Whereas in the green pathway, it's depression and anxiety, leading to suicidal ideation, leading to suicide attempt. So these are two different pathways. And just to make this more clear, our theory now, our working hypothesis, is that there are two pathways to suicidal behavior in adolescence. One is an interpersonal pathway. I have an interpersonal distress. I develop an internalizing disorders, which means either anxiety or depression. I develop suicidal ideation, and then I make a suicide attempt. So that's one pathway. And the other pathway is usually an externalizing disorder. These are children with conduct disorders, health risk behaviors, drug, juvenile delinquency, leading to health risk behaviors, NSSI, and the suicide attempt in the second pathway. And these two pathways we think should be treated differently, and there are different ways to prevent them. Again, this is in our country and in Europe, but whether or not the same two pathways exist in other countries is something that would be interesting to see, look at in the Guyana project. In terms of assessment, we talked about suicidal ideation, and I think what can be very useful in underdeveloped countries is monitoring suicide using digital platforms. So this is the one that we're working on in Israel, but there are many in different parts of the world, and it's using passive digital markers to see whether or not an adolescent is approaching a suicidal crisis. So we can look at mood using acoustic recognition, looking at voice recognition, because people who are depressed have different voices than people who are not depressed. You can see how active the adolescent is. You can see how well they sleep. And you can look at different forms of cognitions in asking the adolescent to do different cognitive tasks using the phone. And using this, we monitor our adolescents from our suicide clinic. And I said using these apps, and this just shows you how the material looks. It looks very strange, but this is an adolescent who we saw there was a change in the digital markings that were recorded on his phone, and this was a sign that this adolescent was in danger of making a suicide attempt. So we're using this, and the advantage of using these technologies is that they're cheap. Even in the most underdeveloped countries, people now have phones, and they mean that in places where you don't have a large staff to follow the patients up very closely every week, these could be very convenient, and also it gives parents a feeling of more confidence that their child is being monitored, and they don't have to hire a private detective to follow them all the time. But this is interesting. The other major project that we're doing, looking at different therapies for suicidal adolescents. So most of you know CBT for suicide prevention, CBT-SP. Unfortunately, CBT has not been proven very successful for suicidal adolescents. It's been very good in adults, but work by David Brent and work at Cambridge, Ian Goodyear has shown that CBT is probably less good for prevention of suicide in suicidal adolescents. But IPT, which is basically quite a simple therapy, has been proven very useful in our hands for suicidal adolescents and preventing more suicidal events in kids who've had a suicidal crisis. Then there's some very interesting third-generation behavioral techniques, such as DBT and mindfulness-based therapy, that can be helpful, but they require a high level of skill of professionals, and this should be further down the line. But one therapy that we found very useful is a nonviolent resistant parent management training, which I'll show you a little bit about, because I think it might be something that you would find useful. But nonviolent resistance is a method which was actually developed by Gandhi in India for fighting the British occupation in India. And it's been adapted for dealing with conduct disordered adolescents or adolescents who don't respect authority at school or at home. And we've developed a program in our hospital which has been quite successful. And it's a therapy which has been described in the literature, and we've published the details of this therapy, which you can you can see it in publications. We recently published an article on this in the European Journal of Child and Adolescent Psychiatry. And we found that this is not only useful for externalizing disorders, that is conduct disorders, but it also had an effect on depression and suicidal behavior, which you can see in this graph. So when you think about it, is what gives, when parents feel less helpless, when they feel that they have control of the situation, this confidence actually increases morale in their adolescent children, and actually prevents suicide as well as preventing externalizing behavior. So you can see the effect on internalizing behavior was even stronger than externalizing behavior. By internalizing behavior, I mean anxiety, depression, and suicidal behavior. So this is something also which might be a useful tool in treating suicidal adolescents who are mainly externalizing in different countries. The last thing I want to talk about is medications for depression. This is a case which you may or may not have heard. This is Christopher Frank Pittman, was a famous, became famous. He was a bright young adolescent. He then became depressed. He was treated with Prozac. And then while he was on Prozac, he actually murdered his parents. And this brought up the whole problem of suicidal behavior related to the use of Prozac or antidepressants in adolescents, which has become, I'm not sure what the situation is in Guyana, but these medications are used all over the world for treating depression in adolescents, and they have an important role to play. But one of the problems with these medications is that they increase suicidal behavior. So this is a famous study called the TADS, the Treatment of Adolescent Depression Study. And what you can see is that fluoxetine, although it helped with the depression, it increased suicidal behaviors quite substantially. And this seems to be due to the fact that, in line with the EGESA theory of problem behavior, these medications often activate young people, causing insomnia, behavioral activation, over-arousal, restlessness, agitation, irritability, hypomania, and even mania. And so we see these suicidal behaviors actually increased by the antidepressant medication. So again, this is another pathway for suicidal behavior via the health risk behavior route. Okay, interestingly enough, when we look at the biological markers of this SSRI, these antidepressant-induced hyperactivity, it's associated with changes in immune levels of an immune protein called IL-6, which in itself is related to hyperactivity. So it's possible that these drugs, by changing immune reactions, may cause hyperactivity. And it's not a subject, it's not something I'm going to talk about here. It's not really pertinent, but the relationship between immunology and suicide is now something that's really a very hot topic. But it's important for us because I'm not sure what the situation is with antidepressants in using antidepressants for adolescent depression in Guyana, but I'm pretty sure that probably it's used because it's so popular everywhere. And if it's not used now, it's going to be used. And it's something that clinicians have to be aware of. Okay. So this is the treatment guidelines for adolescent suicidality. You have to make a safety plan. In other words, if you feel that you're suicidal, let's see what you can do, make a safety plan. We've got to work with the adolescents about keeping to the safety plan. You decide on appropriate levels of care. It's important to know that hospitalization is not necessarily the best treatment step for hospitalization. Many adolescents who kill themselves do it in a hospital. And try and understand the chain of events that that lead to suicide. So it's important to establish treatment guidelines, which probably need to be adapted to each culture. And what might be true in Israel may not be true in Guyana. And it's something that's worth thinking about. And it's, when we do this project, it's something that I'd really like to see if we can use these kind of treatments, interpersonal therapy and nonviolent resistant therapy in the context of these treatment guidelines for preventing suicide in this country. So Vladimir has already talked about prevention. To a large extent. What's important in this slide is a slide from David Schaffer to show that if you just rely on patients who come to the emergency room, probably the chances of preventing suicide are not very good. And I think probably Vladimir's already made the case that if you really want to prevent suicide, you can't just stick to the emergency room. You have to go out to schools. And this is the young study which Vladimir has already talked about, so I don't have to do this. And so I can conclude. Adolescent suicide is a major public health problem, even though most adolescents in the Western world do not kill themselves. I'm not sure what the situation is like in Guyana, but I would imagine it's even more serious. Adolescent suicide is not one problem. It's a complicated set of problems, each one requiring a different solution depending on the contents and setting. Adolescent suicide is very much an epidemiology. It depends on the country that you live in and the culture. The dramatic epidemiological shifts and suicide rates go up and down over the centuries. Some epidemiology of suicide is very interesting. One way of preventing suicide is encouraging adolescents to ask for help. This is very important in countries which have a kind of a macho approach where men can't ask for help. And probably one of the reasons why in Western countries men kill themselves more often than women. Treatment of suicidal crises can be very brief. Our suicidal treatment program is only 5 sessions, and it seems to be very helpful. In those children whose suicidal behavior is within the context of behavioral problems, health risk behaviors, delinquency, ADHD, then parent management training, the nonviolent resistance program for parents may be helpful. And of course, the SADE program is a very interesting intervention in this respect. So thank you very much. Is there any questions? I'd be happy to answer them. Otherwise, somebody listening? Is somebody who's monitoring this?
I'm listening, but not monitoring.
Okay.
So far, there are no questions in person at this point.
Okay.
Oh, wait, sorry, there's one question. Someone's coming. Oh.
Hello?
Hi.
Was there a question?
Oh, sorry, they were just asking about the posting of this video. Anyone else have any questions? It's a question in the chat. What is the percentage risk of increased suicidality with SSRIs?
It's definitely there is an increased risk. It's quite common. But when I talk about suicidality, we're not really talking about suicide, but of suicidal health-related self-harm behaviors. It can be quite high, between about 1 in every 10 kids or adolescents who get SSRIs. Maybe I can just show you. This is a very famous study called the TAD study, the treatment of adolescent depression. And as you can see, these are kids who were with depression. So 34% of kids with depression responded to placebo. 43% responded to CBT, which is interesting that CBT is not a very good treatment for adolescent depression. And this negative result has been seen in other countries, in other studies, such as in Goodyear in Cambridge. Fluoxetine helps in 61%. But even when you add CBT, the fluoxetine, the suicidal behaviors are still quite high. So you can see that if you give fluoxetine, it's more than a double chance of the adolescent developing suicidal behavior. So it's something that's really important. Biological child psychiatrists, they get very angry when you show them the slide, but it is a problem. And as I said, CBT is not very helpful. We're still in the early stages of our studies, but we think that IPT might be a better alternative for adolescent depression. But definitely, if you do give an SSRI, in other words, Prozac or an antidepressant drug to adolescents, you have to be aware of the activation syndrome. And once the kid becomes activated, it's very likely to do some kind of self-harm.
Can we just speak? Can we, or we have put questions in the chat? How does it work?
I think you can just speak.
Okay.
Yeah.
Hi, Dr. Apter. It's Larry Amsel from Christina's group.
Okay.
Just a little question on that though, because we worry about that message to psychiatrists, but also to primary care clinicians, because there was also some evidence that when primary care clinicians got frightened off using SSRIs, that the suicide rates went up because of the lack of their fear of prescribing. How do you square that circle?
Okay, well, you can see I have a slide prepared for that. That shows you.
Yeah, that's the slide I know. Yes, sir.
Everybody knows that slide. It's something you have to worry about, and it's a problem. It's a clinical problem. There's more suicidal behavior with these medications, but there is more suicidal behavior with medications. Some people get very angry when you say that, especially John Mann, if you're talking about Columbia. But you see it all the time, and it's a problem that you have to be able to recognize and deal with. It depends on the clinician. So you have to train people to manage suicidality. It's not a reason not to give SSRIs to adolescents, but when you give an SSRI to adolescents and you see activation, you should be aware of the problems with suicidality.
I guess that's the key point though, right? Whether or not it's a reason not to, right? Because it's a subtle point, right, that sometimes doesn't come across.
No, in the hands of a good clinician, there's no problem. But just to say that there's no problem, I think is not probably not true.
Right. Thank you. And just a follow-up question on that would be, so it sounds like what would be so important then is to have evidence that IPT would be an effective alternative, let's say for mild and moderate depression at least, and so that clinicians have that alternative.
Well, we're certainly working on it. We have a publication I can show you if you're interested in the. We've had a big problem with. It's interesting. The suicide rate in adolescents in Israel has gone down. On the other hand, the suicidality rate has gone up, and so our emergency room is flooded with suicidal adolescents. And we haven't been able to cope with all the patients coming to the emergency room. So we've developed this very brief intervention which is 5 sessions. And we're studying it. We've seen about 100 cases already without major, they haven't gone into major problems, but we'll have to see how that works out. But the suicidal behavior seen with antidepressants is very interesting from a biological point of view. And it's also a major focus of our studies, of looking for the markers of increased suicidality with SSRIs. And as I said, seems to be related. It might be related. One of the markers that seems to come up is these interleukins, these immunological factors. So it's really very, very interesting. And it's interesting clinical problems. But I'd be interested to know in Guyana how much antidepressants are used with adolescents. We'll have to find out.
Well, thank you so much for this talk. And I'm going to put a plug in. I'm talking on Thursday on using decision theory ideas in suicide. So those who are interested in this topic, I'm talking on Thursday on that. Okay. If you don't mind my advertising myself on your time, Dr. Apter.
Sure, no, that's fine. Okay, thank you for your questions.
Well, we teach primary care. We do a lot of teaching of primary care clinicians, and that is the #1 issue, Dr. Apter. The #1 issue is their fear of prescribing the medication.
Okay. That's a very interesting problem.
Thank you, Dr. Apter.
Okay, thank you.
Thank you so much.